What we'd like to do now, and again, this is being video recorded in lieu of taking notes and that kind of thing, but we'd like people to share your experiences, to ask any questions that you might have. This gentleman here said he had a question that hopefully he wrote down. We'll start by answering some questions, and if you want to talk about things that are happening to you, you know, in the general terms that we talked about, you know, like providers are getting rate cuts, not sure how that affects my family member, et cetera, we can have a conversation. We've got a whole hour left in our forum, and really we wanted to turn it back to you because it is a forum. We want you to have an opportunity to express what's going on and see at what level we might be able to help. So, gentlemen, we had a question.
Yes. My daughter has semi-annual staffing with CHP, and at those meetings there's a caseworker and always a registered nurse that accompanies her. She does nothing. She doesn't participate, she's just there. During a meeting, sort of an open forum that CHP put together, I queried the CEO about what's the necessity of having that person. And his response was, our contract with the state requires that. And one, I don't believe him because he said a lot of untruths during the meeting. But at any rate, I was wondering if that is in fact the case, whether the state is making them do that, and if so, why? Because if your side initially talked about cost effectiveness, and that flies in the face of that.
Well, let me answer your question. First of all, it is a contract requirement, so he did tell the truth on that. It is a contract requirement, but it's one that the current administration is questioning. And if you look in their plans for sustainability, you would see that they are trying to evaluate how many nurses need to be in place for people who are otherwise medically healthy. If you're a healthy person, do you in fact need a nurse case manager to accompany the other case manager, or care manager, I guess they're calling it, the care manager that is assigned to the person. So there was a lot of feeling that it actually was expressed before the audit was done. That was one of the big issues, was duplication of services. When you look to see how many people are employed by the managed care organization who do things that are similar to what's being done by the community providers, including medical staff, you know, most people who are in the community right now have an association with a doctor, a nurse, etc. And so we felt like, a number of us criticized this and felt like that was redundant to have another nurse present who didn't really have a function other than to do maybe paperwork and take a blood pressure reading now and then and that kind of thing. So we thought it was unnecessary expense, and in fact, there is a reference in the current Department of Health Services Sustainability Plan for Family Care to evaluate how they're going to change that requirement in the contract for a nurse ratio for people with developmental disabilities.
If I could say just a little bit more about that, I mean, we're really talking about one of the fundamental issues in managed care, and that is when you pay for a certain thing, is it something that adds value, and the value here is it going to help people? And just so we go through just the very basics of managed care is an MCO gets a certain amount from the state every month to take care of people. And so say it's $3,700. $3,700 a person. That means some people get taken care of for $2,000, some for $3,000, and then some for $10,000, and it's all supposed to average out. One of the really controversial things is that about 20% of it across the state goes to pay for stuff at the managed care organization. Yeah. And one of them is the registered nurse. So let's take $700 off the top of the $3,700 we've got, and that's what's left. So that's a huge question. And then the other thing is to look historically at what we told providers of services for people with developmental disabilities to do, and I'll tell you what we told them. Back when I was first working to get people out of certain institutions. We were starting to close the first couple of institutions in the state 30 years ago. And what we heard over and over again was group home providers didn't have the sophistication to hire people, to handle people with medical needs and behavioral needs. So states and counties, the state and counties told residential providers, get going on this. Hire nurses, hire behavioral specialists, train your staff, because we need to do a better job of caring for folks. And so a lot of providers went and did that. I think we've got some really top-notch services across the state. And now what's happening, of course, is MCOs are coming in and saying, you cost too much. Well, a place that specializes in running a medically fragile group home that has nurses available is going to cost more than one that doesn't. And so that's one of the challenges. And so I think the most controversial part of this is saying, oh, we're putting the nurses over in the MCO. So maybe we don't need those nurses and behavioral specialists and everybody in the organizations that actually are serving people. Well, guess what? The nurse at the MCO isn't going to get out of bed and drive over to the group home on Main Street when somebody has a temperature at 2 in the morning. But that's why they're employed over at the provider organization. So once again, we're going to have some serious thoughts about where we want to spend that money.
You know, one of the things that has occurred around the state is that as managed care organizations have got going, there's been some efficiencies that have been accomplished in terms of cost. And so some of the earlier pilot counties have a cost that's being compared to some of the managed care organizations that came in later. And it doesn't really look, that comparison doesn't really look at what's happened over time. So, for example, here in this area of the state, Northern Wisconsin Center was downsized. You all know that. A lot of people who came out of Northern Wisconsin Center had intensive behavioral support needs. Organizations that provided those supports were offered at the time that the downsizing began to occur back around 2003, 2004. They were offered somewhere between $300 and $400 a day to take care of these individuals. I was giving testimony at the state senate a couple weeks back on the Family Care bill, and one of the things I mentioned to remind the senators of was that this did take place here, and that in fact one of the members of my association, when they were testifying to the audit committee, said, you know, they were among the group that took people out of Northern Wisconsin Center. This is Chippewa County Healthcare Center. And Chippewa County Healthcare Center was getting a rate that was somewhere in that neighborhood, between $300 and $400 a day. And when the managed care organization came in, they were offered a rate of $75 a day to take care of those folks. Well, they basically said that's not feasible. There's no way we could do that. So what they did was they went and they converted the person over to IRIS. They got a rating for an exceptional rate for services, and they were able to continue serving the person because they got a rate that was going to work. But that's the problem here, is that somewhere along the line, there's what's called, you know, anytime you have a contractual relationship, there's an offer and an acceptance. And if they're offering something that doesn't work, then you can't accept it. And that means that some people may not have services in the future who need them. And that's a real key issue here, especially for people who were made promises, who came, you know, people who were promised that they would have community services and that they would be adequate when they came out of the state institution. Those people need to have those services, and they need to be fairly compensated for them.